Recording should be excellent. So, welcome everybody. My name is Eduardo Hariton. I'm one of the physicians at RSC Bay Area. And what I'd love to talk to you about is my passion, which is infertility and what to expect, how to treat it. To level set a little bit, let's talk about what we're going to learn today. We're going to learn about the basics parts of the female reproductive systems, what are the leading causes of infertility, when to seek an evaluation, and then the most common infertility treatments. And I'll walk you through those in a lot of detail. So, 9 grades bio. So, you need 4 things to get pregnant high level: a uterus that can carry a pregnancy, fallopian tubes that are open and can allow the eggs that your ovaries will release to meet the sperm. The ovaries need to be releasing eggs and healthy eggs for that matter, and the sperm needs to have good quantity and quality to make sure that it can fertilize that egg. The normal menstrual cycle works like this. Your brain or your pituitary gland makes a hormone called FSH, or follicle stimulating hormone. Your ovary has a given number of eggs, and every month, if you're having regular cycles, one of those eggs is selected. That egg grows, and it's that yellow one that you see here, makes some estrogen and feeds back into the brain. And this usually happens once a month. If you're not pregnant, you'll get a period at the end of that, and the cycle starts over. And all of the eggs that were not selected that month, they were going to die. So that's kind of how the process looks like. And that's important to know because we'll talk about how we can manipulate that to improve your chances. As you get older, as you may have heard, fertility declines with age. So the chance of getting pregnant every month goes down significantly once you get into your 30s and definitely after 35, and it's under 5% by the time you hit 41 years old. So there's a meaningful decline. And there's 2 reasons for that. The first reason is the quality of the eggs goes down. So there's more abnormalities in the eggs that are released, and that leads to a higher miscarriage rate. And you can see the miscarriage rate for women after 35 starts doubling every half decade. The other thing that happens is that you have a lower quantity. So you have less eggs left in your ovary. And this varies by different women. Some may have a higher than average, lower than average, but everybody is going down over time because women are born with all the eggs they're going to have, and they release them over their lifetime until they hit menopause. So when you put those things together, you have less eggs at a time and a lower number of normal eggs, which makes it harder to find that healthy egg that we need to get someone pregnant. When you think about who should be seeing a fertility physician, we define infertility as 12 months of trying to conceive in women who are under 35 and have regular cycles, and 6 months of trying to conceive if you're over. That's because time is more of the essence, so we want to see you a bit sooner. I usually tell my patients over 40, at least get in here to see me and just have a conversation. Doesn't mean you need to do treatment, but getting pregnant after 40 is harder, especially if you want to have multiple children or just getting started. So I want to see those people and educate them. Other reasons to see me sooner than that time would be if you're having irregular cycles of birth control, if you know your fallopian tubes are blocked or you had a tubal ligation, if you've had a history of pelvic surgery, perhaps a pregnancy that was ectopic and had a tube removed, if your partner has a semen analysis, if you need donor sperm because you're single, you're LGBTQ, or there's other reasons, or if you find that you have a genetic condition that you're at risk of passing on to your children, we can often screen for that and prevent that from passing with something like IVF. So all of these are good reasons to see me. And then the other one, which doesn't really apply to people who are infertile or having issues getting pregnant, but a lot of patients I see, is if you are getting older and you want to preserve your fertility by either doing egg freezing or embryo freezing is another reason. Why does infertility happen? Many causes. It can be ovulation disorders, it can be structural issues in your pelvic, endometriosis, blocked tubes, um, different endocrinopathies like hyperlactin, thyroid issues, but often we don't find it out. We test everything looks normal, and we just can't figure it out. And that might mean because medicine is not enough advanced enough to test for that, or we just haven't figured out the way. But what I wanted you to take out of this slide is that it's not only a female problem. It's that's always the assumption, but generally About a third of infertility is related to the male, about a third to the female, and about a third is a combination of both. So it really is important to evaluate both partners, and we often find that what people thought they had is not necessarily what they have. So then we think about how do we evaluate fertility. So if you come into my clinic, we'll spend a lot of time talking through your history, understanding any risk factors for problems, understanding your goals as a couple, how many kids you want to have, where you are in life, when do you want to have that next child, and think it through. And then we'll spend some time doing testing. So how does that work? We often do a transvaginal ultrasound where we look at the uterus, we look at the lining of the uterus, we look at the ovaries, we count the number of eggs that you have. We can do some blood work to also check your ovarian reserve. One of those is that FSH that I showed you in the first slide, or follicle stimulating hormone. And another way is the AMH, or anti-Mullerian hormone. That gives us a sense of how many eggs you have in your ovary and how you may compare to other people your age. We, to evaluate the uterus, we also can do a saline sonogram where we put some water inside the uterus and look with an ultrasound, make sure that there's no polyps or scarring. In this case right here, you're seeing a polyp denoted with the white arrows. We then can check the tubes by doing something called a hysterosalpingogram. There's other ways to check it too, like a hycosi, but we can put some contrast in the uterus and watch it spill out the tubes and make sure that those tubes are open, so that if you're trying or you're doing an IUI where we rely on the tubes to help the sperm and the egg meet, we know that they're open. And lastly, we of course check the sperm. So we check for quantity, quality, morphology, volume, different characteristics that help us predict whether there's sufficient quality sperm to get someone pregnant with traditional intercourse or with IUI, or if we have to rely on other more advanced treatments. We also test other things to make sure that pregnancy is going to be as safe as it can be. So we can test your blood count, your blood type, your thyroid. We can check for infectious diseases that the state of California mandates us to do, and most states do. We check preconception labs like varicella and rubella. These are labs and infections that could affect you severely if you get them in pregnancy or not immune. So we often do those ahead. We offer carrier screening, which is screening for mutations that could affect you if you were to pass them on to your child. Oftentimes we find that one partner might carry one bad copy, but the other partner does not, so you won't be at risk. But for people who we find might carry the same mutation, and these are things like cystic fibrosis, sickle cell, Tay-Sachs, we can help screen embryos to make sure that they're not passed on to those children, because they can be pretty debilitating conditions for the future generation. And then, of course, if there's issues going on, like your cycles are irregular, you have PCOS, you've lost a pregnancy or more before, your reserve is really low, we can always tailor and add on some labs to do that. So then we move into kind of what are the things that we can do. And this is probably where we'll spend the most time on this talk today. We have really three big things that we do. One of them is control ovarian stimulation and IUI, or insemination. The other one is IVF. And the last part is third party, donor eggs, donor sperm, surrogate. I'll walk you through the first two in detail and make a couple comments about the third, but that's a little bit more nuanced. And I see that someone is asking me, should I bring any past blood tests or ultrasounds to my first appointment? Yes, please do that. Send it to us ahead of time or bring them in, because I love to make your first visit with me as helpful as possible. I would love for everybody to have all the perfect labs ahead of time, because we have a ton of time together, but definitely bring them. I love when someone has a folder and just hands it to me, because I can be the most helpful possible. So let's keep going. There. So IUI, how does it work? With IUI, we're basically augmenting what's happened naturally. Or if you're not ovulating, we're helping induce that ovulation. So we have you take 5 days of pills, usually Clomid or letrozole, also called Femara. And what this does is that it helps your brain make more of that FSH to try to make sure that you're ovulating. If you make one follicle normally, you might still make one, you might make two or three, but that helps increase the chances of finding that healthy egg. We bring you in for an ultrasound around day 10 to day 12, although that can vary based on your cycle. And once we know we have the optimal number of eggs at the optimal size, we help release those with an injection of HCG, which mimics what your cycle's doing in the middle. So mimics that LH surge that happens from your brain and helps those follicles release every month. Then we bring you and your partner or donor sperm or however you're doing this 2 days later for the clinic for an insemination. And an insemination feels like a long pap smear. We put a speculum in the vagina, we take sperm that we washed and concentrate, and we put it all the way at the top of the uterus, where it's like 95% of the way there. The idea is to get more sperm closer to more eggs. When you talk about what's the likelihood of clinical pregnancy, it varies by age. It's typically in the 15th to 18th percentile per cycle for people who are under 35, and it starts to go down as you get closer to 40 and past 40. And that's because the majority of the eggs that you might release are going to be abnormal. So it's going to lower the chance of getting you pregnant. So age is an important factor in whether we counsel someone to start with IUI or whether we say, looking at these numbers, how do you feel? And then we think about the next treatment. I'd say the majority of my patients who are going through this look at the cumulative 3 cycles, which is typically what we do. And they say, do I feel good with 20 to 25% chance of getting pregnant over 3 cycles, or do I want to move straight to the next thing, knowing that I might be there anyways in 75% of the chances? And that is a very personal decision that I help them do, but I help my patients kind of decide for themselves. The next step of treatment is IVF. So if you remember this from the beginning, this is what happens every month. Brain makes FSH, one follicle grows, everything dies. And what we try to do with IVF is that we want to rescue those follicles that were going to die. So we give you the medication by injection. They're very small needles that you inject into your belly, and we try to get all of those eggs to grow to maximize the probability of finding those healthy eggs. You do this for about 1.5 to 2 weeks. You're coming in for ultrasounds every so often. We're getting blood draws to try to understand what your estrogen levels and progesterone levels are doing. And once you get those little follicles to the optimal size, which usually on average takes about 11 days, we try to start that releasing process. So we give you a similar trigger injection, but rather than let you release those eggs, we want to get them out so that we can get them in the lab. So exactly 36 hours after that injection, we do something called an egg retrieval. You come to our office in the morning, typically, you get an IV so that you get some light anesthesia. You're breathing on your own for the most part, unless you have a reason not to, where they need to support you more. But for the majority of patients, you get an IV, you take a nap that takes somewhere between 10 and 25 minutes. You get pain medications through your IV, and we go in with a needle and we aspirate all of the follicles. So we get all of that follicular fluid out, we give them to our embryologist. What it looks like on a calendar basis, we typically have you take some oral pills from anywhere from like 9 days to 3 weeks. That helps keeps all the follicles small so that everybody starts the race together. You then get a period either before or after the pills, and the part that we consider the cycle is the injections part. So you usually have an ultrasound before, which we call a baseline, and then you come in on day 5, day 7, day 9, etc. And we kind of play it by ear based on how things look like. If we might need to bring you every day, sometimes you're ready and you just had 2 or 3 ultrasounds. It really depends. But once we give you that trigger injection, then 36 hours later, we're getting those eggs out. And when they come out, they look like this, kind of on the top left, a little dark spot surrounded by cells. We can surround them with sperm, which is what's called conventional insemination, or we can get rid of that layer of cells and zoom in to find the eggs that are mature. For the mature eggs, we can go ahead and fertilize them with something called ICSI, which I'll show you. But it's important to know that if you or someone you know is doing the egg freezing process, it ends right here. All of the mature eggs, if we wanted to preserve them as eggs, we could just do egg freezing. And that's something that a lot of women are doing these days to try to preserve their fertility for the future for the reasons I mentioned. We have less eggs as we age, and we have lower quality eggs. So many people are trying to preserve them when they're young so that if they need them, they can use them when they're older. With ICSI, what we do is that we take a needle and we put the sperm right inside the egg, and that's called intracytoplasmic sperm injection. We then are your first babysitters. So we have that embryo in our lab, and it starts dividing from 1 cell to 2 cells to 4 cells to 8 cells, and so on until it reaches the blastocyst stage. This is the stage in day 5 or day 6 where we have about 100 to 200 cells. One of the things that we can do nowadays is do genetic testing on those embryos. So we can aspirate about 5 cells from the part that becomes the placenta called the trophectoderm, and we can send that for genetic testing. This is, less necessary when you're younger because you have a lower likelihood of having abnormal embryos, but definitely very helpful as you get older because you might get 3 or 4 embryos at a time, for example, but maybe one, maybe none, maybe two are normal. So it helps us really prioritize those embryos that can help you build your family. For most people, the chance of having a normal embryo in a cycle is high when you're younger, and it starts to go down when you're older. But the important thing to think about is this is for the average women with the average ovarian reserve. If your reserve is higher than this, those percentages would go up. If they're lower, they would go down. And the reason why we do this is we see higher pregnancy rates per cycle as as women get older when we use PGT compared to not PGT, and that's a genetic testing. That's not because we make the embryos any better, but rather because we're much better at picking them, and because we're picking from a pool that as you get older will have more and more abnormal embryos. The other thing to think about is the likelihood of miscarriage goes down because we are excluding embryos that are abnormal. It's important to know that the miscarriage rate is never zero, no matter whether you're transferring a normal or an abnormal embryo. Um, but it's still meaningfully lower than it would be if you didn't know and you transferred just based on how the embryos looked and not based on their genetics. When we get that normal embryo that we call euploid, meaning the right number of chromosomes, we are very successful at getting people pregnant. So there's about a 60 to 65% chance of pregnancy per euploid embryo. Of course, the more follicles we start with, the more we'll get out, the more we'll have mature, the more we'll fertilize, average 80%, the more that make blastocysts, on average 40 to 50%, and the most that more than test normal, and that's very based on age. But you can see ovarian reserve is an important component of being successful in IVF because the more eggs that we get, the more eggs that we're going to turn into embryos and hopefully into babies from there. Sometimes it takes more than one cycle to get there, but certainly if you're someone who has a lower reserve, we can overcome that by doing more cycles. So maybe we don't get all the eggs that we need in one cycle, but maybe we do it over 2 or 3, whereas someone else might be lucky enough to do it in one. Once it's all said and done, the embryo transfer part is pretty straightforward. So we would typically take the embryo, put it in a small catheter similar to the IUI, and then drop it at the top of the uterus while we're looking with an ultrasound. So I tell all my patients, and some of these I've told you before, but I always like to review it because it's important. The number of eggs we get varies based on ovarian reserve. So the more eggs you have, the more eggs we'll get. We'll do our best to get the most possible in a way that is safe for you. All mature eggs are fertilized unless we are asked not to. And I'd say 98% of people fertilize everything because they want to maximize their chances. Some people have religious objections not to fertilize more than they need, so we might go a little slower. Not all embryos will grow, so like I said, 40 to 50%, and not everything that gets frozen will survive the thaw. So it's, very close to 98% in our lab, but there's still a possibility that it doesn't, and we evaluate that, very frequently to make sure we're doing quite well. The number of embryos that you need to achieve your family size is varies based on how many kids do you want and your age. And sometimes it takes more than one cycle. So one of the things that I do is I try to set the right expectations with my patients ahead of time so that they know what to expect. And I always want to beat the expectations, but certainly I want them to be prepared. no matter how many embryos we freeze, there's no guarantee that a pregnancy would be obtained. So I do a lot of embryo freezing for the future in couples that come to me a little later in life or want to plan for their family while they have coverage or whatever the reason might be. And I say, if for every embryo that we have frozen, we have a 65% chance of success, if I freeze two or three, that gives me an 80 something to 95% chance of being successful. But that means out of 100 couples that I help, 5% might transfer three embryos and not get pregnant. So it's important to know there's no guarantee, even if we can make the odds heavily in your favor. Other thing to think about is sometimes people who have struggled might still get pregnant. So just because you haven't doesn't mean a spontaneous pregnancy couldn't happen, unless of course the tubes are blocked or there's no sperm or something like that. And then lastly, we want to transfer one embryo at a time. I know some people who have struggled for a while want to have twins and kind of get the show on the road and get babies in their arms quicker. But twin pregnancies tend to have a much higher complication rate, and sometimes are born so premature that the babies can have long-term issues. So we really work hard to get you pregnant with one embryo at a time. We can expect for you to be bloated and tired. Some people get bruising at the injection site, some feel a little bit more emotional. There's no increased risk of breast and ovarian cancer. I say that because it was floating around Reddit and many people were asking me, so now I just tell everybody. There's a very low chance of complications. Ovarian hyperstimulation syndrome, which is when we hyperstimulate the ovaries, is extremely rare nowadays, and the chance of having an infection or bleeding or damage to an organ is less than 1%. So very, very safe procedure. We're going to have you not exercise because we don't want the ovaries as they get large to be bouncing around and risk twisting. That's called an ovarian torsion, and something that is exceedingly rare, but we try to minimize the chance of that happening. So then when we take a step back, and I know that was a lot of information, and you think about what does IUI look like, what does IVF look like, and how should I think about it? So IUI is less invasive because all you need is that one procedure, no anesthesia. You're taking 5 days of pills. You're taking one injection, so less medication. It's lower cost, but the success rates are meaningfully lower, and I'll show you that. There's a higher risk of having twins or triplets because when I'm helping two or three follicles grow, on average, not all of them are going to be normal, but you could be the super lucky person where all three were normal and all three fertilize. And that can be a pretty high risk pregnancy. So we try to avoid it, but it's unavoidable to some degree when you're doing IUIs. And then you can bank for the future, meaning the outcome of an IUI cycle is either pregnancy or no pregnancy. You can't really have anything saved. When you think of IVF, it's a lot more involved. So you're coming in for more ultrasounds, there's more medications, so daily injections, there's small needles, you take them into your belly, kind of like an insulin syringe, but still a little more involved. The cost is higher, but the success rates are much higher. We can transfer one embryo at a time, which makes the risk of having twins 1 to 1.5%, and that's a risk of an embryo splitting into two, which we can control and can happen in nature too. It's not zero, but it's much lower than with IUI, and you can plan for the future. So a lot of my patients who are starting their families later in life, and they say, Doc, I want to have 2 or 3 kids. I'm not necessarily worried that if we can't get them pregnant with an IUI, I'll have an issue. But I worry that if they do get pregnant at 39, they'll come back for baby number two at 42, and then for baby number three at 44, and we're going to really struggle. So what I often counsel those patients to do is to think about, let's make some embryos and save them so that when you come back later in life, we can use your 39-year-old eggs that we know are genetically normal if we test them to get you pregnant, and then we can decide what we do about this pregnancy right now. And I've had people go back to IUI and do that. Most people, once they do IVF, they stick with IVF, but it's an option to do. When you think of success rates, these are our rates here at RSC. You can see success rates for IUI in the blue are meaningfully lower and go down over time. With IVF, they're higher. They also go down over time meaningfully, but we can make up for some of that decline by using numbers. And of course, with IVF, is very ovarian reserve dependent. So the more eggs you have, the more we'll get, the higher those numbers will be, and vice versa. If your reserve is low, those numbers have to be slightly adjusted down. I want to talk about donor for a couple of minutes because I know using your own eggs is not necessarily something that's an option for everybody. Um, Donor eggs are eggs that come from someone who's likely younger and has a good ovarian reserve. It can be from a bank of eggs where those eggs have been extracted. It can be from someone who does a cycle just for you, or it can be from someone you know who you're like my sister, my niece, or someone who says, I want to do this for you to give you the opportunity to have children. And if a genetic connection is important to you, that's often a good path to explore. But when you look here, you can see patients who do fertility treatment and they are using their own eggs, the chance of getting pregnant goes down. And these are when they don't do genetic testing. When we do genetic testing, they're going to be higher, but there's a lot of cycles where we might not have an embryo that's tested. So if you transfer all the embryos and you didn't do genetic testing, you can see the rate goes down. If you take a donor embryo and you transfer it into the same kind of patient, so older women who are 40, 42, 44, the rate of pregnancy stays the same. So we know that we can overcome a lot of the infertility that happens by using eggs that are normal. Another way to look at this is, and I know these are the extremes of age and, not when the average patient comes to our clinic, but we do have some patients that come at 45, 46, 47, and you can see the chance of being successful in treating those patients, it's about 3% per cycle at 45, half a percent their cycle at 46, and there were no pregnancies reported in these studies after 47. We at RSC do IVF with your own eggs until 45. We do not do it after 46 for exactly this reason. Even with a lot of eggs, we're almost never successful and it just doesn't feel right. So we often counsel these patients to think about donor. And for some people, that's the right choice. And for a lot of my patients who didn't consider that and went through it, it is an incredible way to help families grow, but it's not necessarily for everyone. So that's important to know and acknowledge. So, what is the right treatment for you? It really depends. It depends on your age. It depends on how many kids you want to have and when you're starting. So, when are those kids going to happen in the future in your ideal world? It depends on your workup results. So, how is your ovarian reserve? How does the semen analysis look? Is it enough? Are the tubes open? If they're not, we can't really do anything but IVF. There's always financial considerations. These are not inexpensive treatments. I am very encouraged by the fact that we're seeing a lot more coverage by companies, by states, and I hope that continues to happen because no one should have to think about mortgaging their house to do this, but that's the reality. And I understand a lot of my patients can do some of the treatment. So I work with them to find the best, most cost-effective way to help them grow their family. And then, of course, prior history. Have you tried something before? Do you have anything in your history that pushes me one direction or another? So those are all kind of things that we talk about. So to kind of go back to what we hope to learn, the basic learning objectives I think we accomplished. So we talked about the female reproductive system, we talked about the causes of infertility, we talked about when to see a fertility doctor, and then what are the common treatments in, I think, a lot of detail. A little bit about me. So I got my medical degree and an MBA from Harvard. I did my residency in OBGYN, which every fertility physician does at Brigham and Women's at Mass General, and then did my infertility training at UCSF in San Francisco. I practice at RSC Bay Area, and I also work at the corporate level with our corporate parent, US Fertility, where I help run our innovation fund, where we look at different ways. I love thinking about how we can use technology to make our outcomes better and the patient experience better. I also want to tell you about our group. So we have 10 physicians total across the Bay Area, 4 nurse practitioners who are awesome, and a big team of sonographers, case managers, financial counselors, everybody really committed to helping our patients build families. We have an office in San Ramon, an office in Oakland, an office in San Mateo and Los Gatos, and you can really go to any of these offices. Our procedures currently happen only in San Ramon, soon Menlo Park as well. but we're committed to taking care of patients. Sometimes it can feel scary to go to a big group, but for my patients, I make all of their decisions. I help them through their treatment. When things aren't working as we expect, or if we have unexpected findings, I get to think about it with 9 other people who have been doing combined for more than 100 years. So it's very exciting to be part of a big group. And I think it's usually gives us the ability to take great care of patients. So thank you for coming. This is how you find me. I love educating, as you can hopefully tell from this talk. So you can find me on social media or LinkedIn. I try to post content that is helpful to a lot of my patients. And I hope that this talk was informative for you. So what I'll do now is I'm going to go ahead and stop sharing, and I'm going to stop this recording.